Good morning, everyone. I'm Stephanie Sellers from the Cardiovascular Translational Lab at the University of British Columbia and St. Paul's Hospital. We're very happy to have you join us today for our quarterly translational research seminar series. Today's topic is on emerging and new valve designs for transcatheter aortic valve replacement. I'm thrilled to have my co-moderator, David Meier, with me from Switzerland. David, if you'd like to introduce yourself.
Hi, everyone. It's a pleasure to be here with Stephanie and you all. As Stephanie said, I'm an interventional cardiologist based in Switzerland.
And of course, we're proud to present this seminar series in partnership with ViVitro. I'd like to introduce you to Karim, who is the president of ViVitro. Karim.
Good morning, everyone. I'm Karim. We are proud to support the research at the Translational Lab in St. Paul, Vancouver, and really contribute to the advancements of in vitro testing in cardiovascular space and heart valve therapy. I really hope you'll find this webinar on new valve designs interesting and productive. Stephanie, David, thank you very much for hosting the session. And thank you to our guest speakers, Dr. Meduri, Dr. Lim, Dr. Joshi for joining us. I hope you enjoy the webinar.
Great. Thank you so much, Karim. So for those of you attendees, we'll just remind you that this is in the webinar format. So any questions you may have can be entered into the Q&A. We do have the option to move you into the panelists, and you can ask questions verbally as well. You'll just have to type that in the Q&A, and Christian, who's nicely facilitating this, can make that happen. And so we have three speakers today that we're very happy to have join us. Scott Lim from the University of Virginia and the University of British Columbia, who will talk to us about the Laguna tech valve. Christian from Meduri from Karolinska, Sweden, who will talk to us about the new DurAVR AVR from Antares. And then Srujana Joshi, who will talk to us about her brilliant work making a new polymer valve. So with that, we'll kick it off. And first up, we'll hear from Srujana and hear about her great work on polymer valve.
Thank you for the introduction. I'm just going to share my screen. Okay. So good morning, everyone. My name is Srujana Joshi, and I'm a third-year PhD student at the Georgia Institute of Technology in Atlanta, US. And my work focuses on developing a bio-inspired anti-calcific and anti-thrombotic polymeric TAVR. So this work actually started with the universities mentioned below, and it now has spun off into a startup called Young Heart Valve, where we're trying to commercialize this, but I still definitely feel we're in very early stages. With that as my introduction, let me introduce our team. So we have Dr. Prasad Dasi at Georgia Tech, who is our founder and CTO, and he has expertise in heart valve engineering. And on the other side, our other co-founder, Dr. Susan James, is over at Colorado State University, and she is our in-house material science expert. And our CEO, Mr. Todd Tomba, he has 30 plus years experience in medtech product development. We also have an esteemed medical advisory board with whom we collaborate to ensure our design fits into all of the clinical practices, or if there are any design considerations to be made, we definitely take all of those inputs into consideration. So TAVR is an extremely fast-growing emerging field, but it definitely has certain pain points. Existing TAVRs are limited with their performance due to durability, calcification, structural valve degeneration, and they are also plagued with leaflet thrombosis, paravalvular leakage. Moreover, these issues limit their device lifespan and also necessitate reinterventions. These are also very costly and complicated to produce. They have like thousands of sutures that are done manually, and it's a very time-consuming process. So because FDA has recently approved the use of TAVR into low-risk patients as well. Existing TAVRs are not very suitable to cater to this population. So what we aim to do with our valve is address these performance and production challenges head on. And our solution comprises of a bio-inspired polymeric valve that would have antithrombotic, anticalcific properties and can also perform with excellent hemodynamics and durability. So let me take this opportunity to introduce to what exactly that material that we're using. So our bio-inspired polymeric valve is a fusion between engineering and biology that yields remarkable results. Our foundation lies in linear low-density polyethylene, or LLDPE. So this is a polymer that has been widely used in the packaging industry for its exceptional tear strength and durability and other mechanical properties. And what we do is we incorporate this LLDPE with HA, which is hyaluronin, a biomolecule that is abundantly present throughout our body, including our native leaflet tissues. So HA possesses inherent antithrombotic and anticalcific properties. And when we treat HA with LLDPE, what we get is a composite material, HA-LLDPE, which is essentially the best of both worlds. It takes all of the biocompatibility properties of hyaluronin, but also retains all of the properties, mechanical properties of LLDPE, making it very suitable for hemodynamics and durability. So what I want to point out here is that we're not treating HA as a surface coating onto the polymer. It actually is the integration of HA into the bulk polymer network, so it creates a fundamentally distinct material. So just an example is LLDPE as a polymer is naturally hydrophobic and HA is hydrophilic. So when we treat it with HA, the resulting composite is actually hydrophilic in nature. So that's what I meant by creating a fundamentally distinct material. So let me now dive into what our preliminary results have been so far. So we've had successful animal studies that have shown promising results. When explanted, our leaflets were in pristine condition with no calcification or thrombosis on them, and at no point in time were the animals administered with any anticoagulate therapy. So our leaflets are 80 microns in thickness, and that allows for them to be precisely 3D shaped, which yields an excellent hemodynamic performance. So as you can see, this is a video, an on-fast video of our valve in an in vitro test setup, and it boasts a minimum pressure gradient of 4.77 and a large effective orifice area. In combination with our thin leaflets, we also have a computationally optimized cobalt chromium stent that is balloon expandable, and this has been optimized so that we can ensure crimping for a successful transcatheter deployment. It also has a low profile, as you can see here, to ensure optimal coronary access. The leaflets have surpassed 200 million cycles in the accelerated wear tester and have met the ISO durability requirements. In addition to our leaflet and stent design, we also have a proprietary dynamic sealing technology, or DST, that fits below the stent. And this is essentially our robust defense against paravalvular leakage. So the idea of the DST is that it would expand or swell into the gaps between the native annuli and the deployed valve, creating a robust and reliable seal that will prevent paravalvular leakage. And we believe this would be very important for complex younger patients, especially with bicuspid morphologies. So to highlight our manufacturing process, what the technique we used is something that's called vacuum thermoforming. So what this essentially is you have a sheet of LLDPE as shown here, and that is heated and formed onto a mold of the shape of our leaflets, and then the leaflets are taken off the mold and assembled onto the stent, as you can see here, with minimum sutures. So because this vacuum thermoforming process is so precise, it allows us to 3D shape the leaflets, and it has been designed to mimic the curvature of the native leaflets. So this shows a video of the vacuum thermoforming process. So the vacuum thermoformer has a vacuum pump which sort of sucks in the LLDPE to nicely form it, capturing all of these details. And this allows us to have we envision a scalable automated manufacturing process. And I also wanted to highlight that our entire stent valve, everything is completely devoid of any animal tissue reliance. So it uses completely off-the-shelf material. So our future work would focus on design optimization of some of the elements to reach design freeze. We would also like to perform some particle image velocimetry studies to study sinus washout and meet the ISO 5840 standards, and perform crimping and re-expansion studies to understand the crimping profile of the valve in patient-specific aortic routes, and maybe if we need to work upon that, that would be a part of our future work, and also repeat acute and chronic animal studies with a larger sample size. With that, I'd like to acknowledge the NIH SBIR Phase 1 for funding this work, as well as the Georgia Research Alliance, and all of my lab members at the Cardiovascular Fluid Mechanics Lab at Georgia Tech. And I'd be happy to take any questions. Thank you.
Thank you so much for your great insights into obviously what's been a large amount of work to really start to push forward a new design and approach to a polymer valve. And it's really exciting to see where you guys have gotten to. For our attendees, we'll just note that, remind you to again, put your questions in the Q&A. We will be doing a Q&A at the end of the session, which will not be recorded, so you're free to have an open and active discussion. We will do one question in between as time allows, and it looks like we have time now, so I'll just go from the top. From one of our attendees, Srujana, how does HALLDPE absorb water and swell, or does it?
So it does swell, I think. Let me go back. I'm not very familiar on the chemistry side of things, but I can answer to the best of my abilities. But it definitely does swell, so it's hydrophilic. But I think with the treatment of HA, in that treatment process, we do have a process that sort of cross-links the HA as well. So I think that would sort of limit the swelling, so it doesn't swell up a lot, and then that's why that also holds in the hyaluronan inside the LLDP network. Hoping that answers the question.
Oh, that definitely does. Thank you so much. So we'll make note of the other questions that are here and get to them at the end of the session when we do our large Q&A. But thank you again so much for sharing, and we'll now move on to our second speaker, Dr. Krista Meduri, from Karolinska, who's an interventional cardiologist there and has the CMO of Anteris, and will present on their new DurAVR transcatheter heart valve. Thank you so much, Chris.
Great. Thank you, guys. And I really enjoyed that last presentation, so thank you. So I'm an interventional cardiologist as well as the chief medical officer for Anteris Technologies. And I think it's a pretty interesting story, so I want to kind of set you up a little bit with it, and then we'll walk through some of the science. But, Anteris actually is a company previously called Admetus that's been around for almost 20 years. And it really started with a cardiac surgeon, as most of these problems do, that had seen a clinical problem, which was calcification. And over a period of 20 years prior to this, he actually was, I like to call it, developing his own secret sauce, essentially, of trying to make the ideal pericardial tissue actually for either patch technologies at the start and eventually valves. And he over time was able to develop something called the adapt tissue technology that's actually been used in over 55,000 patients worldwide to date, now is FDA approved. And what he has done with that technology is made something that is glutaraldehyde free, alpha gal free, and free of really any type of residual DNA. And so the hope with that is that it is a less of an immunogenic response. And as we're seeing, we're talking about polymeric valves as well, trying to deal with this idea that the tissue technology itself was delivering some form of the degenerative process. So that happened. And then through that, around 2017, the company recognized that there was this huge space in TAVR. And so they assembled 8 physicians. I was one of them. There were some of the higher volume operators in the US and said, hey, listen, we want to move into this space. We've got this tissue as a platform. What do we need to do? What does that valve need to look like to address the unmet needs in the space? And then over the last few years, or the few years of actually a lot of tweaks and working on that, it led us to actually our first surgical case and eventually our first in human case in 2021 and to where we are today. So a bit of a journey of applying a tissue technology that we believe really has minimized the anti-calcification process and can move things forward in the valve durability process. So in that first meeting, we were all sitting around and saying, well, what do we really want? And these are guys that are, the leaders of the Evolute trials, the leaders of the partner trials, all of us high volume enrollers. And we said, listen, there's things we like on both sides of technologies right now. We think about the balloon expandable platforms. We like that it's a short frame height. We like that it's incredibly easy to use. Obviously, there are other advantages as well. But on the other side, as we just saw with the SMART trial coming out just this last week, there's some advantages that typically are connotated with the self-expanding side, though I think we'll see today don't necessarily have to be. And that's that they tend to be supraannular, and that usually means better hemodynamics. They maybe are better at commissural alignment. And there are some other things, maybe thrombogenicity, washout, and some other things as well. And so we said, well, what do we have that we can actually do that can make the best of both of these things? And so that is what the backbone of developing DurAVR. And it is a short frame, balloon expandable, easy to use valve that we really do believe, as you'll see clinically, provides optimal hemodynamics, very easy commissural alignment. But additionally, we felt it was important, as mentioned in the polymeric discussion earlier, that, listen, we keep making these valves out of 3 pieces that are not what our native valves look like. And so there's an opportunity to build upon that to make something more nature-like that we think will lead better results. And so you'll see that with our unique leaflet design on top of our backbone of our acellular tissue, we thought could really move this field forward. So this is the foundation, and every other transcatheter or surgical valve that's used commercially now really is or primarily is a 3 single pieces of leaflets sutured onto a valve frame that open and close. And this is really the world's first biomimetic valve. And what we've done is we've taken that single piece of adaptive treated bovine pericardial tissue and we've molded it to the shape of the native valve. And you really can only do that by this certain process that happens with the adapt tissue prior to that as well. And what you can see here that it's much more native-like shaped. We actually have a mean coaptation length in patients of about 7.5 or 8 millimeters. And this then leads to performance of a pre-disease state valve. And I think you'll see from the clinical results, it is much different than what we see clinically nowadays with commercial valves available. So again, built on the tissue technology, it's easy to use, balloon expandable, has excellent commissural alignment, and nice large open cells for coronary access as well, all built on a short frame platform. So a couple of years ago, Stephanie and Gennard came down to Minneapolis and started doing some bench tests to really see where do these things compare to other technologies. And I think the things you can appreciate here is, one, in general, this valve definitely has a better hemodynamic performance than any commercially available or in the pipeline valve that's available right now. And that's really due to that 3D shaping. But additionally, if you watch the actual mechanism of opening, it's actually quite a bit different. I believe because each valve typically is built with 3 pieces, the opening of a traditional valve is more of a hinging like this. And as you'll see, as I kind of move this slow motion here, this valve will puff and then pop open. And I think this is what will lead it to much more laminar-like flow. As you can see here, when these valves go slowly open, other valves will not puff like this puffs in the middle here, and then slides right open. So Stephanie did excellent work then comparing this to bench testing with other competitor commercial valves available. And it was first done in a surgical valve-in-valve scenario using all the commercially available valves in these competitor surgical valves. And not surprising based on what I've shown you because of this unique design, it drastically outperformed all the competitors when it came to EOAs and mean pressure gradients across quite a few scenarios. And so I think it was 6 different valve scenarios, every single time in the surgical valves, it had better EOAs and lower mean pressure gradients than all the competitor ones by quite significant margin. One other unique thing not talked about here is this was independent of of depth of implantation as well. And you can see an example here of the differences in really its ability to open, and as well as you'll see a difference in its pinwheeling. Stephanie then and Davide have worked on additionally with our earlier generation, so it's a little taller framing than it is now, valve to actually look at this in TAV and TAV scenarios. So we did an assessment across various TAV and TAV things, which right now really for treating a TAV and TAV, it's really only recommended to use balloon expandable platforms. And so again, we see that DurAVR completely, outperformed the competitive technologies when it comes to EOAs and mean pressure gradients. Again, built on this 3D shaping of the tissue technology. In addition, I think it's really interesting, and we talked about the idea of durability. There's a lot of components, and it's not really just the tissue, but it's obviously the valve, the leaflets, the molding, the interactions with the frame, and their stresses itself. And what's unique here is these valves average a mean coaptation length between 7 to 8 millimeters in humans. And because of that, that really allows the tissue to really lay on itself when it coapts at the coaptation area. And that's almost like blankets hitting each other. It stops it from wrinkling against each other, which then would result in pinwheeling. And I still remember when Becky Hahn had done her first few cases, she does TE cases all the time and said, I've not seen a valve consistently not pinwheel like this. And so when we looked at this pinwheeling index, this is the one valve that consistently did not pinwheel. And we do believe that has clinical implications over time, particularly for durability. And in addition, we then, of course, performed this across various valve scenarios with putting Sapien in or DurAVR in various failing self-expanding processes. And across all these processes, it outperformed Sapien significantly. And again, Sapien is the really only recommended valve for valve scenarios. But, as much as I love this translational research and talking about things that are happening on the bench, I love doing cases all the time. And so, I want to show you the clinical work is the real challenge is taking these things from the bench and from really interesting concepts into transformative clinical results. And so we have had 2 kind of studies that have been ongoing. Our first study really over time has been our first in human series. It's up to 28 patients now. We've treated 50 patients worldwide to date. And I think it's important to understand these are all small annuli patients, so they tend to be have hemodynamic challenges. And despite this being our first in human cases and a lot of early learning, really outstanding clinical results with no mortality, strokes, deaths, big bleeding events, a couple early vascular complication things we were figuring out that are all addressed now, and a quite low permanent pacemaker rate. We sit between this and EFS around 5 to 7%. So really encouraged by that, and actually no significant paravalvular leak in any of these cases. Actually is across all 50 of our patients as well. But I think what's important to see again is the consistency of the hemodynamic impact. So what you see on the left here is our 30-day data. That includes our new improved shorter frame height, but actually also better hemodynamic performing valve. And you can see the consistency of our 30-day hemodynamics there. And additionally, you see that consistently driving out to 1 year as well. We then also have completed our US early feasibility study. And that essentially was looking at the same cohort of patients as well. 22.2 annuli, pretty consistent, both these cohorts with what came out in the SMART trial recently. So what was nice here, and again, this is with our taller frame. Our frame now is roughly a similar height to a Sapien frame, but this was incredibly easy to put in. Operators would be putting these in 30 minutes, stick to finish, saying this is very intuitive, easy to use. We had no PVL at 30 days, all none to trace. No strokes, no deaths, just 1 permanent pacemaker. And as you can see in that bottom left image, that really unique coaptation length that we don't traditionally see. But if you actually ask a surgeon who does aortic valve repairs, that really fits with what they're trying to do when they restore an aortic valve with a mean coaptation length of at least 5 or 6 millimeters for optimal surgical repairs. So this really is lending towards trying to have native-like function. So really, we believe paradigm shifting hemodynamic performance, if you were to benchmark this, and this is all core lab adjudicated out of CRF, this against the competitor technologies, this outperforms but from an EOA mean gradients and DVIs pretty significantly. When we talk about competitive balloon expandable technologies in the neighborhood of 30 to 40% better hemodynamic performance. But I think the story is not just there. And I think, this is what we traditionally think of in the field as EOAs, mean gradients, and some of the other things. But there, I think, is something that is unrecognized, but is going to be a big part of the field moving forward. And that's the restoration of laminar flow. And in order to do that, we do believe that you really have to then build a valve that mimics the native valve, which does have typically quite laminar flow. And what we see is out of our early first-in-human cohorts, that if you were actually to compare this out of the Eurovalve registry to healthy aortic valves, the DurAVR after implantation is the only valve that's clinical or is available that actually restores or has been shown to restore laminar flow compared to a healthy aortic valve. And if you actually look across various other either transcatheter or surgical platforms, it is actually quite remarkable how turbulent the flow is out of those valves. And I believe there's a lot of implications when it talks about energy loss, impact on the ventricle, impact on the aorta, thrombogenicity, washout, inflammation, and many other things that we're just beginning to understand. There's just a paper published in Nature Cardiology late last year that really dives into this topic, and I think it's an interesting one for the future. So with that, thank you for the time today, and happy to take any questions.
Okay, great. Thank you so much. It was a fantastic talk, Chris. Loved how you brought us from that tissue that was not really meant to end up in a valve, and then to the bench testing, and then ending up with that first in human experience with absolutely great results so far. Maybe we'll move on to our next speaker and do all the questions at the end. So next speaker is Scott Lim, who needs no introduction. I'll just say he's the medical director at the University of Virginia Advanced Cardiac Valve Center, and he also recently joined the UBC.
David, thank you.
Yeah.
And actually, Chris, can you stop sharing yours? And I'll share
Oh yeah,
mine.
sorry about that, Scott. Yeah.
Excellent. Oops. Oh. All right. So I'm going to be showing you the slides I presented recently at CRT, which is in Washington, D.C. on the same topic here. And it's the Laguna technology, which was designed for non-calcific AR, although as I'll demonstrate to you, we do have experience with its utility in calcific AS and everything in between. And, I have to confess, I've been doing cardiology for 20-something years, and I've learned over time that AR is not benign, and there's more and more data out about it. But it does present certain challenges when we try and approach it from a transcatheter standpoint. So I got the center part of this slide from my colleague, Dean Kariakis, as he's helping lead the charge with J-valve. One of the other transcatheter aortic valves are being studied for aortic regurgitation, but currently there is no commercially available in North America valve for AR. And AR does pose certain problems that are different than the problems we have with calcific AS. And all of our current transcatheter valves are designed for those issues with aortic stenosis. But with AR, we sometimes don't have any significant cusp calcifications. You can see here on the right-sided examples. We may have a dilated aortic root and the also coexistence of other aortic pathology. And all this means that we sometimes can't see very well how to land the valve, or we have a very asymmetric landing zone, as you can see on the left-sided image. I should note that all three of these images are taken from patients that were successfully treated with the Laguna Tech, either alpha or zeta valve designs. And in a nutshell, here they are. There's two concepts: the alpha, which is a self-expanding design, and the zeta, which is a balloon expanding design. the unique features of these is they have these, what I call leaflet retention arms that come out from the top part of the stent frame, and when fully expanded, act to sandwich the native leaflets around the implanted valve. However, where it differs a little bit between the alpha or self-expanding design and the zeta is what happens in that process, meaning as these arms come out and then the rest of the valve frame comes out. In one design, as you'll see, it pinches the leaflets and holds it as the frame comes up to them. And the other design, the balloon expand design, it acts as a pivot point to pull those leaflets and wrap them around the balloon expanding frame. It comes in size ranges from 23 to 32. I have to say all the experience we have to date is 23 through 29. We don't yet have implanted a 32. Comes in some of the other concepts, a 16 French expandable sheath, and this is dry tissue technology, so eliminating glue. And I'm going to pause just for a moment here. On the left side is the alpha self-expanding, the right side is the zeta balloon expanding. They are both encapsulated designs, but the capsule separates in the midpoint on the self-expanding design versus comes up from the ventricular side up, exposing the entirety of the valve as well as the leaflet retention arms. And how that is different is it relates to then what happens next. As you can see here under fluoroscopy on the left side is the alpha self-expanding frame design. Those arms come out. You push the valve down on the leaflets, grabs the leaflets, and you can see by TE, it looks just like a Meier clip. You're clipping the leaflets, and then the frame expands up to meet it from the ventricular side up. Versus the zeta balloon expanded design, we take the capsule. Oops, here, let me go backwards. Sorry. Let's see if I can get this to play. So we expose those leaflet retention arms, push it down on the valve. We confirm by TE again that we're pinching or grasping all of the leaflets, although I suspect we can do it with probably even only one of the leaflets and still have a good landing. And then as the balloon expands, it forms that hourglass shape, which causes a force on the leaflet retention arms to pull and wrap those around the frame. The other piece I'll play both of them one more time, I think it's important to notice is look at the final landing height. And part of it may be just getting experience. We've only done 12 cases here. And it may be that we were landing the alphas a little bit lower. And so it was anywhere from about 3 to 9 millimeters depth below the annulus versus the zeta stayed relatively shallow in position relative to the annulus. And I think that's important. I'll come back to it. And then when we did looking back on our animal studies at necropsy of the animals, you can see what's happening with these designs. This is the zeta in both these cases, but the native leaflets, which in the animal don't have any calcium, are wrapped and become a paravalvular skirt for the design because it's pulled so closely to the frame there. In vitro testing has been done over 200 million cycles on all of these, and these valves tend to open very large, not in a pyramidal shape at all. And so I'll give you first a human example of each of the valve designs. This is from an alpha self-expanding platform. As you can see here in this particular patient had minimal calcium, just calcium at one spot, but interesting enough, a little bit, not terribly asymmetric annulus, but a little bit that the self-expanding frame conformed to it, and so did not do any post-balloon dilatation because we had no AR and no AS. Aortic valve area ultimately calculated out at just above 3 centimeters squared, so really large opening area there. But despite that, on the follow-up, I think this is a 30-day CT scan, as you can see here on the top right, there still is some asymmetry of the implanted valve. Whether that has long-term durability is questionable, but we probably nowadays tend to think we want to create more circularity. Commissure alignment was confirmed. All of these designs have the independent and axial rotation capability, so you can orient them to achieve commissural or coronary alignment. Here's our first in human of the zeta valve. That's the balloon expanding valve case. As you can see here too, this particular patient had, in addition to the AR, had some amount of AS, had some amount of calcium there as well, as particularly in the left coronary cusp. And this still was able to land very nicely and very shallowly despite that. And the follow-up scans also confirm commissural alignment with this. So our experience in early feasibility, this is all of the implants that were done at multiple locations due to a variety of reasons. Started out in Georgia, once that closed, moved to Latin America in both the Dominican Republic and Chile. And just pulling out these, the first 5 were the alpha, and then the next 7 were the zeta cases. And here are the patients that were done for non-calcific aortic regurgitation. And so we certainly did the spectrum from that all the way up to those that were more highly calcified and combination ASAR lesions. We did have 2 patients that were not successful, as you can see right here. One was a patient that was done with the alpha, and as you can see from the fluoro before, it's self-expanded, and there's a part of the time when it's being deployed when the inflow is widely open, but the outflow is still constrained. Unfortunately, we had a pacemaker issue where the pacemaker discontinued at the just wrong 3 seconds and caused ejection of valve to the ascending aorta. So we then converted electively to surgery for that particular patient. The other patient that didn't do so well is a patient that's on my end. Patient selection matters. We're able to land the valve just fine, bicuspid valve, but significant asymmetry of the ascending aorta, and the patient by 30 days had a type A dissection. That patient did not survive. But everybody else successfully implanted the valve with no residual regurgitation. And as I mentioned before about landing height, particularly with the zeta valve, a lot more variability we found with the alpha, but with the zeta, all the landing height was between 0 to 1 millimeters. This is a very short valve. It's not even as long as the current generation Sapien 3. It's more like, for those that have experience with it, the Sapien XT. But because of these arms, these leaflet retention arms, it allows it to be very consistently implanted. The other thing is, I didn't do all these. I was there for every case, but I was able to teach physicians who it was some of their early experience with this valve, and they were still able to achieve this relatively quickly, and even in some cases without any adjunctive echo guidance, to do this all by fluoro and then subsequent transthoracic. So in summary, this is our early experience with these valve designs, and the goal was to do this EFS with a number of the alpha and a number of the zeta valves, and then the company would make a decision. And fundamentally, the belief is that there is an advantage of doing this balloon expanded design. And so the resources are now being put into doing the next phase, targeting a US and EU EFS with just the balloon expanded zeta design. So with that, thank you. And I'd open up to any questions.
Great. Thank you so much for sharing that, Scott. We really appreciate the presentations by all of our speakers today. I think we've seen, data presented all the way from initial development through bench testing, animal testing, early feasibility, and a various range of approaches to that. And I think that probably is of interest at different levels to our diverse attendees. And so usually we ask